Hi, this is the class prep for the exemplar breast cancer and the concept of cellular regulation. This prep will include pathophysiology of breast cancer, several different types of breast cancer, diagnostics, and staging. How common is it? Well, breast cancer is the most common cancer in the women's cancer in the United States, and it's the second leading cause of cancer-related death, second only to lung cancer. And the death rates, though, have been steadily going down since 1989, and this is thought to be from earlier detection and improved treatments of breast cancer. So that's a wonderful statistic. Anatomy of the breast, pretty straightforward. We have the lobes and the ducts. The majority of the breast is made up with fatty tissue. And the other thing to note is that the breast itself has its own lymph drainage system, and you can see where that is. It goes in the axilla area and then up the clavicle area. So just a review of the anatomy. Breast monitoring, best thing that we have right now is mammography, and this is now digital. As you can see, it's much better than the old x-ray that we used to have. And the mammography today can detect up between 80 to 90% of the non-palpable breast cancers. The schematic on the right-hand side is maybe a non-palpable that shows up very clearly on our mammogram. On the left-hand side of the picture, you'll see this large white area that's irregular. You'll also see where the breast tissue itself has been pulled in. There's an indent there. That is a huge breast cancer seen on mammography. American Cancer Society average recommendation for having mammograms. They say you can start at 40 if you wish, and I put in quotes if you wish. Their recommendation literally does start annually at 45 years old. After that, after 55, every 2 years, because of the amount, the statistics of diagnosing during those years. The older you can live, the more chance you have of breast cancer, but it's the younger folks have a very small risk of breast cancer. So that's was mammograms. Now ultrasounds is another standby as far as diagnostics concerned, and ultrasound is used to find areas of concern. Also, besides finding them, we can measure them. We can actually almost determine what's in it. This is a very circumscribed oval, probably a cyst that's filled with fluid. Fluid on ultrasounds is black. So chances are this is a very benign cyst, which is not all that uncommon in younger women. Over here, the ultrasound has picked up some pretty ugly looking stuff here. And this is what we call infiltrating ductal carcinoma, which I'll show you in a minute. It's growing into the fatty tissue around the ducts and the lobes. So you can see another one down here. This is odd looking. We're not quite sure, but it's the irregular borders that are concerning. We can also stick a needle in there, draw out fluid or cells, put it under a microscope, and it can tell us pretty quick if there's anything to be of concern. 2015, it's the most recent mammogram, not excuse me, clinical breast exam or self breast exam recommendations from the American Cancer Society. And of interest, I put this on here because some people don't know this. Research does not show a clear benefit of physical breast exams done either by a health professional or by yourself for breast cancer screening. So what this says is that it's not necessary to do a self breast exam every single month. What they're suggesting is that women should be familiar with how their breasts look and feel and report any changes to a healthcare provider. Women know their breasts best, and if there's something that is different, looks different, feels different, whatever, that's when you should have a clinical breast exam. It doesn't mean that when you go for your physical, they won't do a breast exam. But again, these are the most current recommendations based on the evidence that we have. So, breast cancer pathophysiology, there's two types. There's non-invasive and invasive. This schematic shows the non-invasive, which is lobular and ductal. There's invasive breast cancer that's also lobular and ductal, and there's some other breast cancers that are they're more rare, and the one that I will mention will be the inflammatory one. And down here it does say diagnosis and assessment, palpation. We were just talking about the clinical and self-breast exams, radiography, which is either the ultrasound, mammography, or MRI, and then actually sticking a needle in it. Ductal carcinoma in situ, DCIS. So ductal, the ducts that we have in the breasts and the lobules. Well, this one is concerned with the ducts themselves. The ducts are very circumscribed. They're lined with cells, and one of these cells goes haywire, and that's when you have abnormal growth within the duct itself. This is ductal carcinoma in situ. Makes perfect sense. It's in situ. That is about 1 in 5 new cancers will be diagnosed as DCIS, and this is almost 100% curable when it's found. Lobular carcinoma in situ is much more rare, but that also means that the abnormal cells are within the lobule itself. Now, invasive ductal carcinoma is just what it says. So it's the ductal carcinoma. Here's your duct, here's your cells gone crazy, and what has happened is that it's broken through the wall of the duct and it's growing into the fatty tissue here. And that's invasive ductal carcinoma in situ. After the non-invasive, this is the most common invasive type, which is the ductal, invasive ductal. The third type of cancer I just wanted to mention to you is the inflammatory breast cancer. It's very different, and it's the diagnostics are very different. It's highly aggressive, and it's on the surface of the skin. It's very rare, and this is literally the skin with these small indentations. They say it looks like an orange peel or peau d'orange in appearance. This is it's more of a diffuse cancer. It's more difficult to treat, and luckily it's more rare too. When you do an assessment, besides feel, you need to look and see what the skin looks like. Now, as far as staging is concerned, you're going to be looking at, is the cancer invasive or non-invasive? Is it within the ducts and lobules, or is it outside? How big is it? Is it 1 or 2 centimeters, or is it 3 or 4? Has it grown through the duct or cell into the nearby areas, and that's in the fatty tissue? Has it spread into the lymph nodes? Has it hit that lymph system, drainage system? If so, how many are involved? Is it 1 node? Is it 12 nodes? Makes a big difference as far as staging is concerned. And has it spread to the other parts of the body? Breast cancer spreads to the brain, the bone, the liver. 25% of the breast cancer that spreads goes to the bone, FYI. So therefore you have your stages 0 through 4, and there's all different stages in between. 0 would mean DCIS or LCIS, and 1 through 4 would mean spread outside the duct, into the lymph, into the bone, etc., etc. So when you look at the staging, it will give you an idea of where and how this cancer has spread. So that's all for now. If you have any questions, please let me know. If not, I'll see you in class. Thank you.